The COVID-19 pandemic created a new population of individuals with chronic cardiovascular vulnerability, those experiencing long COVID or post-acute sequelae of SARS-CoV-2 infection. Even people who had mild acute COVID illness, people who never required hospitalization, are experiencing persistent cardiovascular symptoms months or years after infection. These include exercise intolerance, postural tachycardia, chest pain, palpitations, and elevated inflammatory markers. As this population encounters winter seasons, we're discovering that their residual cardiovascular dysfunction creates heightened vulnerability to cold weather stresses that healthy individuals manage without difficulty. COVID-19's cardiovascular effects are diverse and not yet fully understood. The virus can directly infect cardiac muscle cells, causing myocarditis or inflammation of heart muscle. Even when acute myocarditis resolves, residual scar tissue or subtle dysfunction may persist. The virus damages endothelial cells lining blood vessels, creating persistent endothelial dysfunction that impairs normal vascular regulation. Microclot formation in small vessels has been documented months after acute infection, potentially impairing tissue perfusion. Autonomic dysfunction, dysautonomia, creates abnormal heart rate and blood pressure responses to positional changes and physical activity. These post-viral changes mean that the cardiovascular system is operating with reduced reserve and impaired regulation. When winter arrives and cold exposure creates the demands we've discussed throughout these articles, elevated blood pressure, increased cardiac workload, vasoconstriction, hypercoagulability. A COVID-damaged cardiovascular system may not be able to respond appropriately. Someone who managed previous winters without difficulty might find their first post-COVID winter presents unprecedented symptoms and risks. The inflammatory component of long COVID is particularly concerning during winter. Many long COVID patients have persistently elevated inflammatory markers, continuing months after viral clearance. This baseline elevation means less additional inflammatory stress is needed to reach dangerous levels. Winter's combination of cold exposure, potential respiratory infections, and reduced activity creates cumulative inflammatory burden. The destabilization of atherosclerotic plaques that cold weather induces becomes more likely when starting from an already inflamed state. Autonomic dysfunction in long COVID creates specific vulnerabilities. Normal autonomic responses help maintain stable blood pressure and heart rate when you stand up, when you change temperatures, when you transition from rest to activity. Post-COVID dysautonomia impairs these responses. Someone might experience inappropriate tachycardia, rapid heart rate, with minimal exertion. Blood pressure regulation might be abnormal, causing lightheadedness or even syncope. These symptoms often worsen with temperature changes, making winter's indoor-outdoor transitions particularly problematic. Exercise intolerance affects many long COVID patients through a phenomenon sometimes called post-exertional malaise. Even moderate activity triggers symptom flare-ups lasting days or weeks. This creates a vicious cycle in winter. Reduced activity due to cold weather and exercise intolerance leads to deconditioning, which further reduces cardiovascular reserve. The person becomes progressively more vulnerable precisely as seasonal demands increase. Medical management of long COVID cardiovascular symptoms remains evolving. No specific treatments have been definitively proven effective. Management is largely symptomatic: beta blockers for tachycardia, compression stockings for dysautonomia, graded exercise programs when tolerated. For winter, additional protective measures seem prudent. More aggressive avoidance of cold exposure than would be recommended for the general population. Indoor exercise programs that avoid temperature stress. Heightened attention to hydration and nutrition. Some physicians recommend low-dose aspirin or other antiplatelet therapy for patients with evidence of hypercoagulability, though this remains controversial. Cardiac screening for long COVID patients showing cardiovascular symptoms should include electrocardiogram, echocardiogram, and possibly cardiac MRI to assess for persistent inflammation or scar tissue. Exercise testing can quantify functional capacity and identify abnormal responses. These assessments provide baseline data and help risk stratify patients for appropriate winter precautions. The psychological toll of long COVID compounds cardiovascular risk. Anxiety about symptoms, frustration over medical uncertainty, the isolation that chronic illness creates, depression from inability to return to previous activity levels, all these generate stress hormone release and sympathetic activation. Winter's tendency to worsen mood makes this worse. Addressing mental health as part of cardiovascular care is essential. The emergence of long COVID as a significant public health issue highlights how viral infections can create lasting cardiovascular vulnerability. We're learning, sometimes painfully, that respiratory viruses don't just cause respiratory disease. They can create chronic cardiovascular patients who require ongoing management and who face elevated risks during subsequent winters. For the millions experiencing long COVID cardiovascular symptoms, understanding their heightened winter vulnerability allows for appropriate precautions that could prevent serious events. This is an evolving situation, but the basic principle is clear. Post-COVID cardiovascular systems don't handle winter stresses the way healthy systems do, and protection requires acknowledging this new reality.